Welcome to DM Neurology Made Easy. This is the 10th episode of Fine Neurophilia Quick Revision series. Today we'll see the Epilepsy Part 1 video. So before starting, I would like to thank fine faculty, especially Subir Kothari sir, for giving me this opportunity to converse with you. People who are following the fine can actually confidently continue following fine neurophilia series, even if they are not following any coaching class or entrance learning apps. Because even with this and with few tests and all, most of the students who are following this and following me are able to score good ranks in the institute exams. And it's out of the top 10 ranks in the AIMS this time, April. That is the first exam which they have conducted in 2021. Out of the top 10, 8 were our students. And last year also it was, we didn't advertise it or anything because we are not an app or anything. We are just a teaching session with lectures by faculties. So we had 33 in the top 100, all out of 6 in Sri Chitra, to make you confident that first thing is you have to learn your textbooks thoroughly, first and the foremost thing. There is no substitute for that. Whatever you follow, whatever, but mock exams and all you need to do, that is for sure. But after studying the textbook, you have to have some MCQ orientation of what you have learned. So that is why these kind of modules help you. And how far we have come here in fine neurophilia after starting it in December is this kind of 11 modules. Go through the questions, structure of the question, each part, very important. Then go through the MCQ options. So here we have for starting the session, I had put this question: which of the following is a correct statement according to the latest ILA, which we are following? As you know, ILA has been changing the classification, the definition, and all for long. So that is very important because they can ask in your exams. And the MCQ, these options here are: one is at least two unprovoked seizures, which are 12 hours apart, or whether it is a single unprovoked seizure, which is actually having a 60% recurrence after over next 1 year, or is a diagnosis of epilepsy syndrome, or all the above. So most of them have answered that answer as all the above. You may think that all the above would be the most common answer because that is actually suggested by most of the short, like what you call shortcuts in MCQ answering, that all the above or none of the above could be the answers. But you don't expect that in case of an DM entrance exam, because that usually won't be. So after reading through the questions, you should understand that all these are actually structures for a definition for epilepsy. Actually, all these could be. But the thing is that two unprovoked seizures occurring 24 hours apart actually could be diagnosed as an epilepsy. So you should understand that seizure is different, epilepsy is different. Seizure is a single episode, and to be termed as an epilepsy, we have to have at least two unprovoked seizure or a reflex seizures which are 24 hours apart. Or if a person is having a single seizure, and if you think that there is a seizure risk of about 60 percentage over 10 years, and not just 1 year, over 10 years, then it can be termed as an epilepsy. So in a general population, after getting a one time seizure, the usual risk calculated is about 60 percentage. So this has been given as a breath of air for the treating physician. If he thinks that a patient coming with a first seizure, if he thinks that the patient is has a high likelihood of having a second seizure in a 10-year, he can actually treat the patient with anti-epileptic drugs. That is one. So he won't be medico-legally implicated. That is one reason why they have put this in the criteria. And diagnosis of an epilepsy syndromes. You know about the various epilepsy syndromes. Not only in childhood, even in adulthood, we have epilepsy syndromes which are there. So all the above is not the answer here. Only possible is diagnosis of an epilepsy syndrome. Definitely, we can term it as a seizure disorder or epilepsy or seizure disorder. But the others, there are slight changes. One is this 12 it is not 12 hours, it is 24 hours, and it's over the year of 10, over 10 years and not 1 year. So remember that. So seizure is just a transient event when there is a large amount of electrical activity coming from one part of the brain. If it's coming from a one part of the brain, we call it as a focal seizure. Previously, we used to call it as a simple partial or a complex partial seizure. And if it comes goes and entirely suddenly to all parts of the brain, we call it as a primary generalized seizure. So that is the term for seizure. So seizure is classified as focal, generalized, and unclassified. And you know that to term it as an epilepsy, we have all these three sentences which we have previously studied. So now itself by heart these three sentences. So as we have seen, to term it as an epilepsy, we need to have these kind of these definition criteria fulfilling this definition, that is 24 hours apart and 10 years, and diagnosis could be of an epilepsy syndrome. So what is the risk of seizures after two unprovoked seizures? What do you think is the risk of seizures after two unprovoked seizures? Oh, a single seizure having a 60% recurrence, you definitely have to treat. But definitely two seizures definitely have more than. That is what the studies say. That is the chance of recurrence is actually 60%. These are all simple things you have to know that has got practical implications or clinical implications. So that is the reason why they could be asked in the future entrances. This is in Bradley 8th edition. So now let's see this. So a 6-year-old girl came with seizures with semiology of stiffening of left upper limb and lower limbs with deviation of face to the right side with blinking of eyes. You can see the patient's face, I suppose. And on questioning, she was answering. She was telling her name, which class she was studying. And it lasted 2 seconds. You can see the eye blink. I am talking to her and she's talking, telling her name and everything. So according to ILA classification, this falls under which seizure type? So we are now talking about the seizure type. So you are in your exam, the same question would be like this. No videos would be given. Is it a focal impaired awareness seizure, focal aware seizure, a simple partial seizure, or a complex partial seizure? What we see in a patient is termed as a semiology. What we see. So always in the clinics and even the neurologist or physician always ask you to describe the semiology of seizures. So in semiology, describe what is being seen by you. So in that patient, you have seen that the head is turned towards the right side and the patient is having stiffening of the left side of the body. Head is turned towards the right side. So it's kind of a focal thing. And as you know, the patient is aware. The patient is talking to us. Patient is telling her name, where she is studying and everything. So it's aware. So previously, if it was called, we would have told that as a simple partial seizure. If it was 2010, I was taking this webinar, then we would have answered it as simple partial seizures. But now ILE has reclassified it as focal aware seizures. So you should know the changes. That is why this question. And if there was loss of awareness, that is patient lost her consciousness, she is not able to remember anything, and it lasted just 2 minutes, after which she recovered. So this is actually a focal aware seizures. This is the latest ILA classification. Don't get worried regarding what is happening with these colorful diagrams. It just says that first we had described what a seizure is, as asynchronous burst of activity from a certain region. If it is from one side, it is focal, otherwise generalized, and they have given room for something known as non or unclassified. And epilepsy types, actually, if it is having a particular number of time it's repeating, then it is becoming a seizure disorder or epilepsy. That is focal, generalized, could be combined or it could be unknown. And they have took into consideration the comorbidities which could occur and also the etiological classification as well as the epilepsy syndromes we have discussed in the first slide. So it is just these three things. And what the changes are, you can just see that what we had talked about. all the partial things have been changed into focal. Now we don't have the term of secondary generalized or focal seizure becomes secondary generalized, nothing like that. Focal to bilateral generalization is being used. And there was discognitive, simple partial, complex partial, psychic, secondary generalized, all has been eliminated. You can see these slides. So what changes were made in the 2017 classification from the previous one. So in this patient, we can say we had a focal onset. You know that it is one-sided, and the awareness was actually preserved, and there is motor activity. So it's likely that later it would have further developed into bilateral tonic-clonic. Then it becomes secondary generalized kind of thing. But we don't call it like that. It is called focal onset to bilateral tonic-clonic seizures. So focal onset can be aware or with impaired awareness. So what is the drug of choice for a focal onset seizure? It would be either carbamazepine or oxcarbamazepine. So after starting on oxetol, she didn't have any further episodes. It's the same patient. She didn't have any further episode. This is an adult patient who is also having focal aware seizures. So for this patient, it continued for long. It's continuing refractory to treatment. Oxetol was tried, multiple drugs were tried. So if it continues like this for a long, it is called epilepsia partialis continua. So which of the following statement is incorrect regarding a focal seizure with impaired awareness? The previous patient, what we have seen is a focal aware seizure. Patient was aware. So if the patient having a focal seizure loses his or her awareness, what should not be there from the following statements, which is a wrong statement of the following? So as you know, focal seizures begins with an aura that is stereotypic for the patients. For that patient, the patient would be having aura. Usually, there will be an ictal phase, which is motionless stare, which marks the onset of the period of impairment. And impaired awareness is usually accompanied by automatisms. Automatisms are periodic movements or repetitive movements, which I'll discuss in the future slides. And post-seizure, there will be anterograde amnesia. So what is anterograde amnesia? Anterograde amnesia is something that patient is unable to form. So we know that in seizure, during a seizure, there is retrograde amnesia. Patient won't be able to remember what happened during the time of seizure. So we called to him, what happened, asked him, or what happened to him, he won't be able to remember. That is called retrograde amnesia. But immediately post the seizure, he also will be having anterograde amnesia. That is, he won't be able to form new memories for some time. And also he will be having something called as transient neurological deficit, that is otherwise called Toad's palsy. So he may have unilateral weakness or having a speech deficit or aphasia for some time. So that one of the commonest TIA or a stroke mimic which comes to a casualty is following a seizure. Patient with seizure presenting with Toad's palsy. So that is one more thing. So the answer here is post-seizure, there will be anterograde amnesia, and also the patient can have transient neurological deficit, especially when the patient is having focal seizures with impaired awareness. So usually there will be aura and impaired recollection or awareness of the ictal phase, that is retrograde amnesia. And impaired awareness is usually accompanied by automatisms. These automatisms are like lip chewing behavior, lip smacking behavior, or swallowing. The patient will be doing like this. He will be moving like after the seizures, or along with the seizures, the patient will be having the movement of the lips like that, and swallowing, picking movements of the hand, and display emotions. So that is another highly motor things, like hypermotor behavior can also occur, or manipulative behavior like that. And following it, it can mimic something like a stroke. So there will be aphasia, hemi-neglect, visual loss. If it's occurring from the posterior region of the brain, then the patient will be having visual loss. That kind of things can occur in case of focal seizures with impaired awareness. So studying this classification, you may think it's only for a neurologist, but you have to have some idea. So basic version of this is that focal, aware, and impaired. So it can then generalize it. generalize and form focal to bilateral tonic-clonic. So FBTC, that is the last one. Generalized onset, that is motor, tonic-clonic, and non-motor, that is the absence one, and the unknown onset. So it has an expanded version. Same thing. It is in Bradley. So just identify this. I have put, if you are following my Facebook, WhatsApp, Telegram, and other groups, I would have put the question just for your knowledge. So I am hyperventilating the patient, and for just for less than 30 seconds, I am asking him. He doesn't remember what happens, and he had kind of rubbing his hair, and he was unable to answer to my question. But immediately later, he answered. So what you may have expected one answer in this options, but I have not given it. So this is the fifth question, I guess. Identify the seizure type. So first is the focal aware seizure, focal impaired awareness seizure, focal to bilateral tonic-clonic seizure, or it's a generalized seizure. So this is one thing. Do not make mistake in this. I thought all will answer it correctly as expected, but few are making mistake. Yes, patient is aware, but patient is not aware, because as in the first case, when in the focal aware seizures, if you remember, while asking the questions, the patient was telling the answers properly. The patient was telling her name and class. But in this patient, if you have doubt, so the answer here is generalized seizure. It just means that in the classification I had told you, that in the generalized seizures comes the absent seizures. The generalized seizures comes the absent seizures. So in the generalized non-motor, when there is not much of a motor activity, we term it as a absent seizures. In the absent seizures, there are typical, atypical, myoclonic, eyelid myoclonia. In this absent seizures with eyelid myoclonia is otherwise called as the Jeevan syndrome. Okay, Jeevan syndrome. And typical and atypical absence are different based on EEG and clinical findings. Atypicality would be, in typical absence, the typical 3 Hz spikes. Atypical would be having less than 3 Hz spike, and there will be motor activity, increased motor activity in atypical. But it's not that the typical won't be having any motor activity. The typical will be also having a little motor activity, as seen in this case. So I'll show you the video again. If you can see, when after the hyperventilation, especially these kind of seizures, generalized seizures activates with hyperventilation and photic stimulation. These are the activation procedures. I am asking him his name. He is not able to answer. He's just staring at me, but he has not lost his tone or posture. He's moving his hands and following. You saw the rubbing of his head. So these are mild motor activities which are expected even in typical absent seizures. So the answer here was, it was an absent seizures which comes under generalized seizures, and it's not a focal aware seizures. I knew that some people would have confusion. So just reading the textbook, you may be thinking that you are just reading the theory. So just to make you acquainted with this clinical scenarios, I have put these kind of videos, so that next time you read the textbook, you will be more interested in reading the textbook and grasping the important parts from it. So typical absence are characterized by blank stare, motor arrest, lasting less than 15 seconds. If you see this video was less than 15 seconds. So this individual, the individual is usually unresponsive and unaware, and seizure ends abruptly as it starts. There is no much confusion. After this seizure stop, there is no postictal confusion. That is typical of a generalized seizure. But he must have missed the conversation. So that is the usual complaint. The patient's mother, like a mother going to a parent-teachers meeting, and the teacher telling that the child has become inattentive. His notes, some parts are missing. That is a usual complaint. And mother will be also telling that the child is daydreaming a lot. That is the usual complaint we get. And this child, as you saw, this child also, after getting the seizures, after this academic year, he was having this online class. So our online class with this video, that is photic stimulation. He was having increased photic stimulation due to the laptop videos and all. So that is the reason why there was aggravation in his absent seizures, it seems. And hyperventilation, easier method is just ask him to blow the paper, which I use in my OPD. So you can easily make out in our OPD the absent seizures. And atypical absent seizures are diagnosed primarily based on the clinical features which I have told you, and the EEG finding. That is, it won't be the typical 3 hertz frequency of EEG spikes, but it will be less than 2.5 spikes. So that was regarding the seizure types, that is focal, generalized, and unknown types. So in seizures, the abnormal motor movements may begin in a very restricted region, such as fingers. It will just climb up, march, gradually progress over seconds to minutes to include a larger portion of the extremity. This phenomenon was described by, so it is kind of a marching phenomenon. So it starts in the tip. So if you see focal seizures, sometimes it starts in the tip of fingers or legs, or sometimes it starts as a twitching of the one side of the face. So following which there will be deviation, versive motion of the head, and then it becomes generalized. All people I have mentioned are pioneers or legends in the field of epilepsy: Cahal, Penfield, Lennox. But Hughlings Jackson was the one who described the typical Jacksonian march of seizures. Sorry, I didn't put the option. So William Lennox, Penfield, Hughlings Jackson, and Cahal. So abnormal movements, motor movements, may begin in a very restricted region such as fingers and gradually progress over seconds to minutes to include a larger portion. And this was described by Hughlings Jackson's and known as Jacksonian march, and represents the spread of seizure activity over a progressively larger region of the motor cortex. So it starts from a smaller region and extends to larger region. So some patients describe odd internal feelings such as fear. Sometimes the patient may present with epigastric burning sensation. They usually we get references from gastroenterology department that the patient was having epigastric churning sensation alone, and that is the reason why they went for gastroenterology opinion, OGD scopy, and later, because the gastroenterologist has high index of suspicion, they had referred the patient to neurology because of suspecting seizures. So what do you think is this? And maybe sometimes patient have deja vu, entendo is related to hearing. So patient may have a feeling that they have visited the same place again previously. Even a new place, they may feel that they had that deja vu feeling. You know, the deja vu usual thing described. And deja entendo means have heard the same thing again, means previously, even though when they haven't heard the. And micropsia is small and macropsia large. And these subjective internal events are not directly observed by anyone else. And these are termed as, and these things are called auras, and they have got high localizing values. So depending on where these auras have started, or type of auras, we can sometimes localize the seizures. So if there is visual auras of unformed visual images starting, that is ill-formed images, flashes of light, etc., beginning in the beginning of a seizure, we can tell that these seizures, ill-formed, unformed visual images, flashes of light, etc., colorful flashes of light, etc., then we can say that these are actually from the occipital region. But if it is a formed images, then it is most likely from the temporal region. And if it's an auditory auditory auras, then it could be a lateral temporal region. So this kind of things, auras help us where to localize the start of origin of these seizures. These are auras. So some patients describe odd internal feelings. These are called auras. And these auras are actually kind of a focal aware seizures. because if they don't have this motor component to it, we can term it as focal aware seizures. And auras are typically short in duration and lasting some minutes. And some patients actually with seizures may experience a prodrome. So that are different, completely different from auras, and they are not actually not auras. They are actually a feeling of anxiety, fear, anger, etc. Even minutes, 30 minutes prior or days before, and that is something different from auras. And some auras may actually prolong for longer time. So you may think seizures occur only in humans, but it's not like that. Seizures can occur in all life forms actually. Even amoeba can have seizures, and or even animals, as you can see in this video. So this is having this is a lion having a seizure. If you can see, this is a lion having, I suppose the lion is having a actually intense fear, or I'll let you see the video first. Okay. So first question, you can put in the chat box whether it's a generalized seizure or a focal seizure. Simple question. Nobody is seeing, you can answer it. Yes. Yes, very good. Very good. Very good. Okay. It's actually focal onset seizure, right? So it's actually focal seizure becoming secondary generalized. As we are aware, we don't call it like that these days. We call it as focal impaired awareness seizures becoming tonic-clonic seizures. So if you see the video again, before the start of the seizures, the patient, I'm telling patient and patient again and again, it's actually the lion. The lion was having some kind of aura or a fear, or it could be something else. The lion is actually moving in a gyratory fashion. It is actually looking more towards the right side. It has head turned towards the right side. Usually head turn occurs contralaterally. Right side means it most likely could be, if it is fear, the lion is experiencing fear, the fear factor usually as an aura occurs in case of a temporal onset of seizure. So that we were talking about aura, right? So aura, the fear of aura usually is a temporal, and the lion was looking towards the right side, then it most likely would be a left temporal onset of seizures. And later it becomes secondary generalized. As we can see, the lion is having both upper limb and lower limb generalized tonic-clonic movements, and that is the thing. But since the lion was moving round and round and round, this is could be a special type of seizure which is rare, that is otherwise called gyratory seizures. It's not interest for you, but know that we can, based on the aura, we can actually localize the seizures based on the side, that is based on the head turn, movement of the limb, based on the Jacksonian march, and also based on the aura, if it's in this intense fear, epigastric pain, other things. That I think localization I'll discuss in the next class. Others will. So this is from Bradley I have taken. I'm sure this would be a question in one of your coming entrance exam. I'm pretty sure this will be coming. Wrench is an acronym connected with which one of the following? Wrench. Actually, it's a type of automatism. So automatisms are repetitive motor activities that are more or less coordinated and resemble a voluntary movement, but are not purposeful. So when in the start of a seizure, the patient would be doing something, right? And if that seizure occurs and the patient is continuing that movement, if the patient is writing something or doing something, clapping or something, if it's moving, going on like that, it is called perseverative automatisms. But after the seizures, he is doing some other kind of automatism. It's called de novo automatisms. And the most common automatism which we see is called oro-elementary automatism. It means oro-elementary means something connected with mouth. So usually what we see is lip smacking, chewing, swallowing, and the rarer ones would be ittal spitting. During that time of seizure, patient unknowingly starts spitting and may have gestural automatisms. And one of the non-manipulative upper extremity automatism tends to be rhythmic and it's not related to anything with the environment. And this is otherwise called ringe. That is rhythmic ictal non-clonic hand movement automatism, ringe. So it's there in Bradley. It is in one corner of the Bradley. So this actually automatism. It's not aura. It is not. It is not related with sensory other things. It is actually automatisms. So just keep in mind that such a question is there.